Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs who practice orthodontics. This podcast is brought to you by the American Orthodontic Society. Boy, does it feel good to get back to producing Orthodontic Smiles podcast. I feel like I owe my loyal listeners a brief explanation of why you have not heard from me for a few weeks. Unfortunately, I had a rather serious accident that kept me from producing this podcast that I love so much. Thanks to God, I am healed and feel great and back at the Orthodontic Smiles production studios. My way of saying I'm sorry for the small break in podcasts is to bring you a fantastic guest. He's an educator, an author, practitioner, and an admired intellect. I personally have never met anyone in my life as knowledgeable about the science of orthodontics as this man. His life's work is to instill this knowledge to others. His name is Dr. Frans Currier. In this podcast, you will be captivated by this special man. Well, thank you very much, Dr. Frans Currier, for being on Orthodontic Smiles podcast. This is a thrill for me to be able to sit here and talk to you. I've known you. I just sat thinking about from the first time I ever met you. That was about 30 years ago, Frans. We met each other. And known each other very well. I've followed your career. Those of us who know you very well have followed your career, and we're so proud of you from 30 years ago that now you are professor and chairman of the Department of Orthodontics of Oklahoma Health Sciences Center College of Dentistry. What an accomplishment. I'm thrilled to be able to talk to someone like you. So let's get started with this, Frans. You just didn't start off being a chairman of an orthodontics department. You started off as what? You went into dental school at what school?
University of Michigan.
You went to the University of Michigan, and then, I didn't know this, but you went into the military.
Yes, I was in the Navy in the Philippine Islands during the Vietnam conflict. Wow.
And that was something I didn't even know about you. Can't even picture you in a military uniform, but that's commendable, and thank you for your service.
Sure.
And then you went, guess what? You became a pediatric dentist. So tell me all about that. How did you get to be a pediatric dentist?
Well, one of the things I wanted to do, at that time, you were not allowed in the military to specialize. Specialization was not, the only pediatric dentist in the Navy had done research up at Great Lakes, but there were no specialists in orthodontics or in pediatric dentistry in the military at that time. So you had to go out to do it. And I had one of the advisors for me at Michigan became dean at Oklahoma, and he had advised me a variety of very good pediatric dentistry programs. And so therefore I applied back to Michigan, and I applied to University of Washington in Seattle, and I was accepted as one of three people at the University of Washington, and I was in the double program. I did an internship residency at Children's Hospital, and there was only one per class, and then I did my master's degree at the University of Washington.
Wow, that's the way it was done. I think University of Indiana had some kind of program like that with
Right.
Riley Children's Hospital. Back then, Washington was one of the premier pediatric programs, so you probably got a great education in pediatric dentistry. And did you practice pediatric dentistry for very long?
Then I went after I graduated from UW in Seattle, I went to Richmond, Virginia, to the Medical College of Virginia. It was in the process of changing its name to Virginia Commonwealth University. And I taught there for 4 years and practiced a day a week in their intramural practice system.
Did you always want to go into education, or is it just something that you just kind of fell into?
No, I wanted to be in education. I figured that you could make a significant change with a greater group of people than just relative to individual patient care. So I figured you could have a generational change by teaching people who will therefore treat patients. So it was always in the cards. The only question is, what should be complemented along with a specialty in pediatric dentistry? What should there be besides that? So I looked at other options at that time.
And that other option was orthodontics.
One of the options was an orthodontics. The other one was, should I get an MD degree or should I get a PhD? And it turns off is that I thought that the one that would have the most applicable was to do the orthodontics. And at that time, it was unethical to be a joint specialist.
Ah, okay. I remember back in 73 when I was just getting, 75 when I was just getting out of my program at Children's Hospital of Philadelphia and University of Pennsylvania, that's when they were starting the dual degree program.
Correct.
And I was asked to join that dual degree program, but I chose to come back to Florida and enjoy the sun and fun. But I still ended up learning quite a bit of orthodontics, and some of that I learned from you, which is really, really great. Okay. Well, okay, so then you chose to do orthodontics and teach orthodontics. Did you practice in an outside setting, or the only time you ever practiced orthodontics was in the confines of a university?
Well, or in a hospital. When I left, I treated patients when I was in Richmond, both at the university, but at the Children's Hospital. And then when I went, after I finished my orthodontics at Pennsylvania, I went to Henry Ford Hospital for 2 years because they were supposed to start a graduate program. So I treated patients full-time for a couple of years at Henry Ford in the Detroit area and some of its suburbs.
So that what year was that when you actually?
That was 78. That was 78 to 80.
78 to 80. Well, you've worked your way all the way up the grind to chairman of the Department of Orthodontics. I mean, that is just an accomplishment in itself. I mean, sitting and reading through your CV is a book. It's 43 pages, single-spaced. I mean, you have done many, many things in your life. Author. So many articles you just can't count. You've spoken all over the world. You're pretty world-renowned chairman of a department. So, congratulations to you.
Thank you.
I want to get to the way you think orthodontics is. Is orthodontics the same as it was when you first started?
Well, they were making some tremendous advances. I think that you have to look at where are the advances being made? We've been making significant advances. To just take from the 1970s, at that time, bonding was beginning to edge out banding of teeth for orthodontic appliances. There was also competition with removable appliances, functional appliances that were coming from Europe. But the real thing was going on, what's happening relative to bonding. And bonding, even though it started with Bonacor in 55, it made enormous changes because it took away the amount of band material between teeth that you could now treat things non-extraction that you could not do before. So it was a powerful impact. And it starts in the 70s. It flourishes more in the 80s. And by the 90s, it became commonplace. So probably that in and of itself is an enormous change that occurred. That's the latter part of the last century.
So now look at where we've come. I'm curious about your thoughts about aligners as it pertains to orthodontics now.
Well, I think there's another thing that occurred that began to hitchhike in the late 90s that really has an effect on the aligners, and that has to do with the use of computers. and it has to do with information technology. Let's put it that way, information technology. And in that, with regard to computers and then what could be done, it's the beginning of the possibility of doing all sorts of things. And with that, if you didn't have the computers, you would not be doing anything relative to the clear aligners that are coming. The problem you have, however, when you look at clear aligners, you have to look at clear aligners that are sometimes presented as just a removable appliance. And removable appliances will fail against fixed appliances if you want to do orthodontics on a predictable way. So the only way that these aligners work basically is that you have to put attachments on the teeth in which to do a variety of tooth movements. Can't do them all, can't do them quite as well as you'd like them to be, but you can at least make them much better. But to say that you don't have anything fixed along with the teeth, that's a misnomer and that's a mistake. So you have to look at it as a fixed, it's a removable appliance, but it has to have specific things on the teeth in which to do certain things. And even with that, it can't do everything really well.
Mm-hmm. Well, they've come a long way from their very inception. I was just looking at what Invisalign has come out with, which is the correction of class 2s utilizing Invisalign. They put attachments on the buccal cheeks so that the mandible is held forward, and supposedly that is going to make a difference in the anterior-posterior positioning of the teeth.
Right. Now, the only thing that the other thing that runs that comes in around the time of the computers of the late 1980 or 1990s, and then it comes back into the first 10 years of the new millennium that really comes back off, and that has to do with basically digital versus analog imaging has revolutionized another aspect of it. Now, it's more technical, it is more costly, but it has great beauty in a variety of things that were compromises before. So almost, I mean, the orientation and the standard of the time we're in now is relative to digital, and digital is spectacular, and then you can expand from the digital into 3D, and then you can expand into not only 3D imaging, but now you can come into 3D relative to making appliances, relative to the new 3D approach to making models or making like the trays. Those are all relatively spectacular changes in the last 15 years that are really, and they're all part of kind of a parallel going forward, and they're symbiotic with each other. Now, the limitation with this is that you have to keep in mind that dentistry has had, in orthodontics specifically, they changed the name 30 years ago to orthodontics and dentofacial orthopedics. And the problem is, with these new aligner, even with the attachments, you're doing dental alveolar changes and orthodontic changes. You cannot do orthopedic changes or using orthopedic force systems. And that really presents a phenomenal limitation in growth and development, because in growth and development, not only the sequence and the protocol of how you treat the cases, this has to do anyone in pediatrics all the way up to orthodontics, even into the adult area. The transverse plane, which is lost in your lateral supplementary film, has to be addressed early, and usually it needs an approach that is not dental alveolar, but allows for the basal amounts to change. So therefore, my concern is in the enthusiasm for these, they will forget that you must address the transverse plane. And I see that some people have said that you do sagittal first. Actually, you're supposed to take care of posterior crossbites and posterior parts of the occlusion before you treat the anterior, unless you have some sort of intrusion mechanics that you're trying to do anteriorly. You're not supposed to do that. And my concern is you've turned some things upside down. So as you're getting back what you're talking with these new appliances, I think that the one who is a person who becomes an expert or oriented to that, you have to use these clear aligners as an adjunct to other things, or it should be interspersed relative, usually using a combination of some fixed, then coming back to using aligners, or vice versa. So I think, and that has to be done at the level of people with specialty training. I have a lot of problems about anybody who is just a general dentist who's finished and goes into the wild world of this without a growth and development background. I think you're compromised. I think you're not looking at it the way you're supposed to be looking at it. As a professional and as a specialist, one is supposed to be very much tuned to the concept of chaos theory, which basically is very prominent where we are, comes out of the weather, which means that there's small amounts of change can have profound implications in the direction of the treatment. And that's how you teach. They're supposed to re-diagnose and treatment plan every case, that when you see them, every time you see them on 4, 5, 6, 8 week, whatever the interval, the doctor must see the patient to see, did the things that were proposed, did they work because of growth and or assistance or of the mechanical intervention? So you have to be on top of this. I think the mistake people are making at the time is they don't think this is a growth and development approach. It's done in, because these aligners come out of the adult world. They don't come out of the growth and development world. I think that could be a problem if you begin to get too early and think it's going to be the savior under 20 for all the people, and discarding and actually substituting a removable appliance with some attachments on the teeth as the cure-all for the cases that you're seeing. I think you're going to be limiting the treatment that you would like to see with the spectrum of patients you're supposed to be seeing.
Well, I know that in my treatment with young ones, and when I consider it early mixed dentition, starting at around maybe 7, that's when I start my expansions of both the maxilla and the mandible. But I can understand how later on you can go to Invisalign, but I think the most important time to get involved in helping that child develop an airway, develop broad arches that allow for the mandible to come forward is at a very early age. And that brings up the subject of how does a pediatric dentist get involved in this?
Well, one is now, the idea of airway is like they brought this up as a new topic that we've never really looked at it before. This is actually a topic that has been discussed, and it basically has come back off far more with regard to different curves in the growth curves. And if you take a look at the growth curves, basically there's Scammonn's growth curve, you will look at that the peak of the lymphoid adenoidal tissue is supposed to be around the age of 7 to 10. Now, I'm giving you an average of what that would be. And the problem when you're at that stage is that, and then it begins to involute and fall back, okay? It begins to involute and fall back from its position as it's a strong position blocking the airway. So it is normal to have it be large, and the number of people who get tonsillectomies or adenoidectomies is done very infrequently now unless there's recurrent infections. So at that same time, you've got to now look at the differential of the growth that you will see. And one is the growth in the maxilla still follows the somatic curve, but it is as a powerful neural component because of the eyes. So it matures very early, the maxilla, compared to the mandible, which continues to grow. And that's the area. The other area that blocks the area in that 8, 9, 10-year-old is a large tongue, because the tongue maximizes very early. It follows a different curve. It follows the neural curve. So in the oral environment, you've got a lot of things clogging things up, and you don't have the true development yet of the somatic or the sigmoid curve, because the airway follows the somatic curve. It follows the skeletal muscular system. It needs the oxygen that you have in the process of growing taller or whatever you're going through. In fact, the new indices that they have relative to trying to look at skeletal age They're trying to look at the vertebral index to look at the height of the vertebra, and the vertebrae do change, and whether you buy in totally to the vertebral index, and that is they will get taller and they will get concave on the inferior border, basically close to where the cricothyroid is, around C4. Can be C5. That latitude is from C5, C4 in that area. And that's basically the airway below. And then you can divide the airway up in a variety of different areas. But it is normal to be fairly well clogged up relative to a lot of stuff going on in that 8, 9, and 10. However, one of the things is it is narrow arches that create crowding. It isn't just fat teeth that are creating crowding. So you're absolutely correct. So you need to make sure of that you have proper development of the maxilla in the transverse plane, and the lower arch should be compensatory to that. And you brought out a very good point that you have to look at the curve of Wilson in the lower arch relative to uprighting the lower buccal segment, because the lower segment is trying not to run into crossbite. It will fall lingually toward the tongue. So if you need to, the criteria for expansion in the upper arch might not be a bilateral posterior crossbite. It might be an adverse curve of Wilson in the mandibular arch, which is that not extremely noticeable on a 8 or 9-year-old, but becomes far more noticeable as one progresses into the teen years. So you have to look at both the upper arch and the lower arch transversely, as you've already stated, but it's the lower arch that helps determine how far you expand the upper arch.
Yeah, when you get to that 8 to 9-year-old, then you're starting to see that deep bite be much more accentuated because of what you just said.
Correct. That's correct.
Yeah, so that's why I've always felt like you need to treat, but if you're going to do early arch development, that you need to treat both the upper and the lower. What I find in my community, at least, the orthodontists have a tendency to only treat the maxilla and then wait. They feel as though the mandible will come forward on its own, but I think it needs a little help.
Well, one of the things, keep in mind now, this is to do now the difference between orthopedics and orthodontics. The suture for the left and right mandible fuses by 1 year of age. So there is no transverse mandibular orthopedics. There is none.
Could you say that there is a tipping of the mandible? I mean, a tipping of the bundle that is holding the posterior primary molars and molars.
It's a form of lateral uprighting.
Exactly. That's what I would say.
It all depends. Now, if it's a narrow lower arch, there is a type of case that you must treat early, and that treat early meaning by you try to treat it with difficulty, which is a Brody bite syndrome of a child that is 4, 5, and 6, where as the person puts their teeth together, there's absolutely no vertical contact either on the left and or the right side. Those are complex cases because you will do everything you can to expand the lower arch to prevent over-eruption of the buccal segments in the maxilla. Those are very difficult cases, and you have to do it, and you're not doing it orthopedically. You are doing vigorous amounts of dental-alveolar expansion, and all you're trying to do is to get vertical stops. You'll probably run into problems later on, but those are unique circumstances. But you are correct. You're changing the angulation of the teeth. You're not changing them orthopedically.
Yeah, you can't expand mandibular basal bone. That's for sure.
Yep.
Well, let's get into this then, because we're up for years and years and years. We've been told that if you're going to get the mandible to come forward, you've got to expand the upper first. But there's the world right now is changing as a result of Frans Currier's opinion that you treat sagittal first and don't worry about the maxilla being narrow.
Well, I think the problem there is related to the maturation of the craniofacial complex, and the occlusion is transverse, matures early, and then you work off the sagittal, and the vertical has always been the more complicated because you have to divide it into the anterior part and the middle and the posterior. And the posterior part is closer to not the back of the head, but underneath the ears. I'm not sure. I think the argument about do you have to treat the upper arch and not treat the lower arch? Everyone has been trying to grow mandibles, and you can't grow mandibles. You can make them to get the best phenotypic expression of the genetic potential. There's nothing wrong with that, but to think that you're going to grow mandibles, they've tried to do that in all sorts of different ways, and that has not been successful no matter who it is, under what circumstance. So is he saying specifically that you do sagittal and then do transverse?
Yes, exactly.
Well, I think that
unless you have bilateral cross bites and things like that, of course, then you would treat the maxilla first by expanding, and then go ahead with the motion appliance. But in general, I believe, and I've interviewed him on Orthodontics Smiles podcast, asked him this specifically. He felt as though that you can always address the transverse after you've corrected the anterior posterior.
Well, to me, it's whatever it is. Do not allow the transverse considerations to be lost outside. You must do it within the timing of the growth and development is the critical aspect. If you do it beyond the period of time of growth and development to try to address the transverse plane, you are in deep trouble. It does not work predictably from a surgical point of view. It is a compromise. So one of the things that you learn early, that whatever it is, you must address the transverse plane during growth and development. And if you fail to do that, your success at many different ways is going to be compromised. So I think it's somewhat of an academic. If someone wants the difference of 6 months to a year, if it's during part of the same treatment protocol, I believe that's a nice academic discussion as long as it is addressed. I think that the more traditional one it's worked off fairly well, is to address the transverse, get it set up. Nothing wrong with addressing the sagittal at the same time. But to say sagittal first and then ignoring the other, I think that sends the wrong message. I'm just giving it from a growth and development perspective.
Yeah, you've been doing some research about this whole transverse thing, haven't you?
Yes, we have. We've looked at this. We've looked at this from the 1980s, and we looked at the RPEs and how much did you expand in the premolar. A millimeter, every millimeter you expanded, you increase the arch perimeter by 0.8 millimeters, and that has been used by many people for a long time. So everyone who wishes to treat cases in orthodontics and to have it non-extraction, everywhere as you get it in the area of the fours. You get it in the area of the premolars. You don't make non-extraction cases off the molars. You make them in the mid-arch areas. And everyone has been oriented that you can expand maxillary intercanine width, but you cannot permanent. You cannot expand mandibular permanent intercanine width with any degree of success at all. So therefore, now that's not true for the primary teeth.
That was just what I was about to get to. I'm glad you brought that up.
Primary intercanine width is supposed to increase with the eruption of the centrals, the permanent centrals and permanent laterals. So therefore, that's a different. So you have to, when you ask questions, you have to make sure: are you talking about primary teeth,
right,
or are you talking about permanent teeth? If you're talking about lower permanent intercanine width at the age of 9. If you expand, you're going to have to permanently hold. They will relapse. It doesn't work almost independent of any malocclusion. It's just a problem. So if you shouldn't violate that. That's pretty well accepted. And if you wish to violate it, there are just consequences in which you violate an approach that doesn't work.
I agree. And that's the argument that you get into is that are we talking about intercanine width in the primary or the permanent dentition? That is part of the reason why, at least in my opinion, why if I'm going to expand the upper, I try to expand the lower at the same time, because I think as you push on the primary canines and you expand their width along with the primary molars, you're basically carrying what alveolar bone that surrounds the primary cuspids out with the teeth. And so you actually have more bone in place for the permanent cuspids when they come in. So I think there's more stability in the cuspid area if you expand the primary cuspids first.
Well, the point is there is an expansion for primary. That's true. Now, there are some interesting things under normal growth and development. Under normal growth and development, as the mandible grows upward and backward and begins to come down and forward and rotates, the one area that's a natural place where there is resorption is on the facial of the lower incisors, and that's where the projection of the mandible pagonion comes. That doesn't just do by addition, it has to do with rotation of the lower jaw in that process of becoming more prominent. So there is apposition, normal resorption, a part of the apposition and resorption in the facial of the lower anteriors. That's why it's always risky business to advance the lower incisors in growth and development. Runs actually contrary to the normal rotational effect that you should see in growth and development in the mandible. That has to do with knowing the awareness of what are the different facial types that you have, has to do with your understanding of the mandibular plane angle, has to do with the variety of where is the growth direction, whether you use y-axis or some other parameter. If you have a vertical grower, you do not have the compensation that you would like to see in the sagittal direction. You'll get a vertical component, but sagittally you are more compromised.
Yeah. Well, we've gotten away from the tweed 90-degree incisors.
Yes, but the one thing is, I think that there are certain things that you'll come back off dealing with surgeons. That has to do with, for them, one of the misnomers now that I'm getting concerned about, as I say, it has to do with treating everybody the same way. When you do surgical cases, when you do orthodontic surgical cases, one of the things that they really would like to have is they actually would like to have upright lower incisors, which means you have to take care of the dental alveolar compensations prior to the surgery, which in most cases, especially in class 2 cases, you have to upright the lower incisors. Otherwise, they can't get the results that they want in the process of the surgical treatment. One of the misnomers that is done is to take a case that's a marginal or a case that could be a surgical case or it could be an orthodontic case. You try to treat it orthodontically, you are not successful, and now you try to make it a surgical case. Your chances of success are not high because you have to set the case up totally differently. So the big problem there is you've got to identify, which I think is very appropriate. You have to identify, is this a surgical case or is this a non-surgical case? They actually like the lower incisors upright. If it's too far facial, if it's a surgical case, they have all sorts of problems relative to the treatment. This is very specifically in the area of orthodontic surgery and surgical cases, which are usually outside the scope of someone less than 15 years of age.
Let me get back to the changes that are happening in the world today as far as orthodontics is concerned. Henry Schein Orthodontics has come out with their sagittal first concept, but now they're into an aligner that they're promoting along with sagittal first. So basically they are now promoting the use of the motion appliance to correct the anterior posterior positioning of the molars and then start an aligner correction after you've corrected the molars. So this is, and the reason I'm asking the question is that it's complex. It brings in both orthopedic movements and dental movements, and at the same time, how do you change the way you teach in the university system your new orthodontists?
Well, this you're bringing up the point of who is dominating the conversation relative to orthodontic treatment. Is it the universities and their educational system, whether it's in the dental schools don't do a very good job in orthodontic education, not very good, basically a lot in growth and development and its orientation to intervention. And if you take the graduate programs, which is always a complex issue of what do you have to do, what should we cover? For example, let me give you some examples which are realistic and some that I consider to be not realistic. I think if you're going through an orthodontic program, if you only use removable appliances, you will not be accredited. You have to use removable and fixed appliances.
Are you teaching removable? I mean, I'm talking about Invisalign in your program.
Interesting that we actually introduced it. We've been using it since the zeros, okay, since basically 0, 4, and 5, and 6, and we brought in a specific faculty who did most of it in the state, more than anybody else, and he did it for 7 or 8 years. And so yes, we've been doing it. It has improved over time. So we haven't been fearful of that. That hasn't prevented us. We had to get the TAD's approval from OU with the federal government to use TADs before they were approved as TADs because they were used as restorative implants. I mean, it's the same way relative to using CBCTs. My Lord, we get to see the idea of volumetric changes, and we get to also see airway, and we get to see alveolar bone. So I think the idea of coming off with these new technologies, and by the way, they're just new technologies to make our job of treating patients better. If you lose the perspective that you are actually treating individual patients in families, I think you've lost no matter what you use. So part of this is a philosophic approach.
Oh, absolutely. But let me just carry it one step further. Sure. I know of orthodontists in my community who have not put a bracket on in 6 months. The only thing they're doing is they're elite providers for Invisalign and pretty much have forgotten about bracketing.
But I think one you can do a variety of things when you get to be over 40. Okay, that's you can do a lot of things. One is you know, why do I need to see superimposition? Why? Because they've already got the system down fairly well. Okay, these are experienced clinicians who already know the nuances and the ins and outs of where the problems are. I have absolutely no problem. There is no I'm talking about in an educational program, we're coming in to the novice approach, someone who needs to know about orthopedics and all sorts of things to get to the stage if someone comes back in after many years of the experiences and they want to do it one way. I have no problems with that. I have problems is if they're going to be able to do it with surgical cases, then let's see what they're doing with the surgical cases. That's going to be, if they're doing it, they aren't going to be able to do very much in orthopedics. That's the one thing that they can't do very well.
Right. But let's take it to the next level then.
Yeah.
You're going to sit for your diplomate of the AAO.
Yes.
Are you going to allow Invisalign cases to be presented?
Oh, that is, there's no stop sign to do that. So I don't think I don't think there has been a stop. I think that it's more difficult. I let's just say it's more difficult to get excellent results the same way with fixed appliances in a variety of cases, not in all cases.
But you will accept those cases
it has to just meet the discrepancy index is how difficult the case is, and then the last thing is how your results of your case doesn't meet the same criteria. Everything from root paralleling, marginal ridges, curve of Wilson, just all sorts of other.
Six keys.
Yeah. So I mean, there's no banning here. It's just that you've got to use the same. We've got to use the same criteria of we aim for excellence. Remember, this is like a golf game. Sometimes sometimes you're at par, and sometimes you've bogeyed, and sometimes, my Lord, you've done a great job, and it's better than what you thought. Don't ever think that you're so good that you don't need patient cooperation, and you don't know how to select the right thing at the right time. So growth and development and patient cooperation make us look pretty good.
Yeah. Let me ask you one a little bit of a difficult question that
Sure.
And that is, I know you sit on the board of examiners for the AAO diplomates.
Correct.
The criteria that they have used for years and years and years has changed to the extent of, what is it, from 10 cases down to 2?
No, it has gone from 10 to 6, but they have, just so you know, this is they just had the last session in 2018. In 2019, starting in February, they're using the case scenario based. You will not present cases.
Okay. You do realize that I've interviewed several orthodontists that are quite upset about the fact that they have worked so hard to get their diplomate status, presenting 10 cases, and now going to no cases. They feel as though that it's a little bit difficult for them to swallow.
Oh, listen, I'm empathetic with that approach. I understand the concern. You
presented 10 cases.
Yes, I know, and it's one of those things is that this is I think one of the things that helps if you're in academics. You deal with change constantly because you have people come through your program, so you're constantly changing. You don't realize you're not a marshmallow, but you adapt for certain things. Part of it is you don't control. The only thing you can control is yourself. So to come back over and I try to influence a lot of things. Don't think that I do that. But this idea, some of this stuff is I'm not going along. That's not my stamp of approval. I need to adapt, and therefore to make sure that we teach stuff that is consistent. And we're pretty good because we cover the broad thing. We go from clear aligners all the way to standard tweed edgewise. We do all sorts of stuff. I mean, we've got to cover the basis.
Is this change that has occurred at the diplomate status or position, is that coming from academia or from treatment?
Well, that's a good question. The one who makes the decision is the board itself. Now, the only reason is almost all the boards in pediatric dentistry has already made that, for example, they've already gone to case scenario. Almost all the boards have gone to case scenario based. They have not done to show cases. So this is one of the last groups to do this. And therefore, this has to do with making things psychometrically sound, has to do with consistency, has to do with a variety of variables. So I'm not sure I would not say it's dictated necessarily by one group or the other. It looks like it's kind of a halo effect of what's happening with all the specialties and their examinations.
I'm assuming, based on the way the technology is that they're presenting their cases with digital models.
They can. They can't up until before today, coming up until this new case scenario. You could present them both electronic models and hard copy models. In fact, that's one of the bigger problems that we have. Right now is, for example, we're teaching the wanding besides taking impressions for taking models. I'm big on I have no problem with the new technologies in all sorts of ways. We have relative, the one area at the teaching level, walking in the door, I have a lot of questions about doing everything 3D or doing it without having models in hand. Not at the novice, not as you walk in the door, but you can also have it electronically, and you can make it in other venues besides a hard copy. Maybe we'll do it later on, but right now that's the best three-dimensional awareness. 50% of orthodontics can be determined by looking at models that are appropriately articulated.
Yeah, you're right, I've had a tough transition from plaster in hand to digital display. It's
And yeah, and you're an experienced person. To the novice to eliminate the models and go to the other, we have no. It's a cheap three-dimensional approach. Cheap in the sense of inexpensive.
Well, Frans, we're getting down to the end of our broadcast here, and I'd like to stop for a moment for a message from one of our corporate sponsors.
Hi, my name's Dr. Brad Williams, and I've practiced orthodontics for over 35 years, and over those years, I've had some fantastic teachers like Dr. Bill Wyatt, Dr. Bob Garrity, Dr. Dave Jackson, and many, many more. And I'm honored now to be teaching orthodontics to a whole new generation of general and pediatric dentists. I want to personally invite you to enroll in one of my basic or intermediate hands-on courses through the American Orthodontic Society. We are committed to provide your entire staff the support and training you need to launch orthodontics in your pediatric or general dental practice. And to make the hands-on experience in my classes the best possible, I've partnered with an outstanding and very ethical company called OrthoArch to provide all the orthodontic supplies my students need. When my students start treating patients in their offices, they too will benefit, as I have, in partnering with OrthoArch for all their orthodontic supply needs. You can contact OrthoArch at www.orthoarch.com. See you in class.
Well, Dr. Currier, it's been quite an interesting discussion, but I never get off a broadcast with a person of your status without asking what they think about the future of orthodontics. In other words, you've been around for quite a few years doing this. You should have a better perspective than most of us as to where it's going to go in the next 10 years. So what is orthodontics going to look like in the next 10 years? Where's the technology taking us?
Well, I think the technologies are going to continue to improve. I do think, and that's fine. I have no problems with that. I don't have any major concerns. I think there are certain things that you need to keep in perspective, because if you don't, you'll either get too excited or you'll get too depressed. And that has to do with cyclic phenomena. We go through cycles. We had problems of expanding new dental schools in the 60s and 70s into the 80s, and then we had them all close. I think we've expanded too many dental schools, and they're going to close in the 20s. We're going to see the same thing relative to orthodontic programs. So the problem has nothing to do with interest. It has to do with the student debt. And the student debt is driving things that shouldn't be driven to the extent of the options for the students. In general, for orthodontics, I think the future is very bright. I think that the people coming into it have been very much, we just got done reviewing the applicants. So I think it's I think the numbers, we don't have to have a lot of numbers. We have to do what we have to do. I think it's the only thing is that we're losing a little bit of our sense of the commercialization of certain things. The fundamentals are still in growth and development, and the biomechanical principles are the same. The fundamentals haven't changed. We might make a look at them a little faster, a little better in certain things, but don't throw out all the good stuff. We've got too many other good things. Examples: sudden infant death syndrome. We'd put everybody. We were worried about putting them on the face down, and now we put them in the back, and now they have flathead syndrome because they're putting it too much in the back. It's not the way to go on certain things. So anytime we make the change, it's 2 steps forward, 1 step back. That's okay, but don't lose the fundamentals. The number of people in the academic educators, if the ones who've been for a long time, they've always been rare. They're just going to continue to be more rare.
And you're definitely not one of the rare ones, Frans. That's for sure. You've been doing this a long time. You have a tradition amongst your residents at the end of their completion. You do something special for them that they remember you by. Why don't you tell our audience what that is?
Well, what happens is that they do, first you have to have retreats with graduate students, and you need to get together, and you need to treat them as colleagues, and to enjoy it. So you enjoy the journey while they're here. Ours is a 30-month program. We think it works out pretty nicely. I'll take the most recent one, the last couple classes. A couple of classes ago, the class of 11 gave me my bobblehead. They gave me the bobblehead. The class that graduated in 14 gave me a watch with all their faces on. So they say they were the best class ever. And then the class last year gave me a bow tie with their faces on the bow tie. So what did they do this year? They gave me a nice big broad umbrella with all their faces of the 4 people in the class. So you can take a look up into the rain, and you get to see their faces. So it's part. This is part of the trivia and fun in the journey that we go through.
But you give them something, don't you?
Oh yes, we give them. We give them a variety of things. Yes, I give them, have done for a long time, is to give them a clock that it's a mantle clock with and something on the back of it, and it basically has to do with the concept of time. Time is the 4th dimension, and they each get it. And they get it actually sometime in the 2nd year of the program, near the end of the 2nd year. And that has to do with the tincture of time. You're given this opportunity, so make sure you do the best you can for the time that we have.
Well, let me ask just one last question, and then we
Sure.
can wrap this up. And I can't let it go by because I know you're an excellent pediatric dentist at the same time that you're a chairman of orthodontics. Give me your perspective of where pediatric dentists' education is right now as it pertains to growth and development and as it pertains to doing limited treatment in their offices.
Well, that's a tough question for one of the reasons. In some aspects of it's good. If going back to this 1-year-old thing, that's basically a preventive approach for tooth decay, for anterior tooth decay of primary teeth. And I have no major problems with that. I think the idea of teaching for pediatric dentists should be expert from 1 forward. To say that general dentists should be an expert from 1 forward, I have a lot of reservations about that. I think 3 or 4 is a better thing for them to be oriented toward it. I think the idea of growth and development, this has to do now with the conflict that you have relative to where you get your education in pediatric dentistry. There is a skewing toward going to hospitals, and they're basically using them to treat patients. And the academic component in a hospital program can never be as strong as it can be in an academic program. So the ones that are combined in some are favorable. But if you make it more hospital and less academic, what happens is you get experiences, but are you getting enough of the experiences that can transcend the deficiency of just seeing a lot of patients? And it's important that you see the same patients over time for you to evaluate what happens with the patient over time. That's very difficult to do in any pediatric program. And that, by the way, I consider to be one of the great beauties of pediatric dentistry, same way in orthodontics, is to get to see your patients grow up. I think it's absolutely fascinating. So as I say, you treat individuals in families, and it's a pretty easy course.
Yeah, that's the exciting thing about doing pediatric dentistry is you never see the same patient twice. They're different each time they come in, even if it's sometimes 2 or 3 weeks difference from the time you see them. So it's always been a thrill for me. And Frans, I can't thank you enough for being on Orthodontic Smiles podcast. This has been one of the most technical and advancing podcasts we've had so far, and I can't thank you enough for being on Orthodontic Smiles. I hope you enjoyed it.
Thank you, Ed. I appreciate it very much.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.